Hello, readers of KJR. I'm really happy to have an opportunity to introduce my study regarding the impact of increased chest CT utilization on the diagnosis of pneumonia in older adults. Pneumonia is a major threat to health of older adults. More than 1.5 million older adults die of pneumonia worldwide every year, and this burden may increase with population aging. The demonstration of pulmonary infiltrates on imaging is the cornerstone for diagnosing pneumonia, and chest radiography is the standard tool for this purpose. Chest CT, as a diagnostic tool for pneumonia, has higher sensitivity for mild pneumonia compared to chest radiography. However, because of limited accessibility, greater radiation exposure, and cost, it is not considered as an initial imaging study for pneumonia diagnosis. The accessibility to CT has significantly improved, an increasing number of CT exams has been reported in multiple studies. Meanwhile, population-level trends of chest CT acquisition in pneumonia patients and evaluation of pneumonia burden associated with changes in accessibility to CT has not been sufficiently investigated. So, the objective of this study was to investigate the trend of chest CT acquisition in Korean older adult patients with pneumonia and the association between the trend of chest CT acquisition and population-level incidence and mortality of pneumonia. A cohort database of Korean older adults provided by the National Health Insurance Service was used for this study. The cohort comprised randomly sampled 8% of Korean population aged 49 to 80 years in January 2008 who maintained insurance eligibility at the age of 60 years. The database contains information regarding demographics, healthcare utilization with corresponding clinical diagnosis codes, and survival status between 2002 and 2019. From the database, individuals aged 61 to 81 years at each calendar year between 2009 and 2018 were included for this study based on availability of mortality information. For this analysis of insurance claim database, arbitrary definitions of variables were necessary. An incident case of pneumonia was defined as utilization of medical institution with a main clinical diagnosis code of pneumonia accompanied by the prescription of antibacterial, antiviral, or antifungal drugs. Multiple healthcare utilizations occurring within 30 days of the initial visit were considered as part of a single pneumonia episode. Mortality due to pneumonia was defined as any deaths occurring within 30 days from the initial date of healthcare utilization due to pneumonia. The acquisition of chest CT was identified by any claim for chest CT during the pneumonia episode, and the hospitalization and the oxygen supplemental therapy during the pneumonia episode were evaluated as surrogate indicators of severity of pneumonia. For outcomes of the study, population-level age and sex-standardized incidence and mortality rates of pneumonia were investigated for each calendar year between 2009 and 2018. Rates of pneumonia with and without chest CTs were separately evaluated in severity subtypes stratified by hospitalization and supplemental oxygen therapy. The age and sex standardized frequency of chest CT acquisition in patients with pneumonia and 30-day mortality rate of patients were also investigated in each year. The insurance claim data of more than 900,000 older adults were included in this analysis. From the database, about 190,000 pneumonia episodes were identified, and about 3,000 mortality due to pneumonia were identified. The population-level incidence rates of pneumonia showed a modest increase between 2009 and 2018. During the period, the incidence rate of pneumonia with chest CT acquisition was continuously increased, while that of pneumonia without chest CT acquisition remained relatively stable. The incidence rate of both hospitalized and non-hospitalized pneumonia showed similar trend of modest increase. The incidence rate of pneumonia with chest CT acquisition increased in both subtypes. However, the incidence rates of hospitalized pneumonia without chest CT acquisition decreased, while that of non-hospitalized pneumonia without chest CT acquisition remained stable. Similar trends observed in severity subtypes according to supplemental oxygen therapy. The incidence rate of pneumonia with chest CT acquisition increased in both subtypes. Meanwhile, the incidence rate of pneumonia with supplemental oxygen but without chest CT decreased during the period. However, the incidence rate of pneumonia without supplemental oxygen nor chest CT acquisition remained stable. Looking at the population level mortality rate, there was a modest decrease between 2009 and 2018. During the period, the mortality rate of pneumonia with chest CT acquisition increased, while that of pneumonia without chest CT acquisition decreased. Similar trends were observed for both hospitalized and non-hospitalized pneumonia and pneumonia with and without supplemental oxygen therapy. Between 2009 and 2018, the frequency of chest CT acquisition in pneumonia patients continuously increased from 13.4% to 20.4%. During the period, 30-day mortality rate of pneumonia patients showed clear trend of decrease from 2.1% to 1.7%. Similar trends of increasing chest CT acquisition rate and decreasing 30-day mortality rate were observed for both hospitalized and non-hospitalized pneumonia and pneumonia with and without supplemental oxygen therapy. Let's move on to brief discussion about the result of this study. The frequency of chest CT acquisition in older pneumonia patients significantly increased between 2009 and 2018, both in relatively mild and severe pneumonia. Potential contributors of this phenomenon may include increased accessibility to CT, patients' demands on sensitive and accurate diagnosis, and defensive practice of physicians. The population-level incidence rate of pneumonia with chest CT acquisition showed trend of increase during the period, both in relatively mild and severe pneumonia. Meanwhile, the incidence rate of pneumonia without chest CT acquisition decreased in relatively severe pneumonia, but unchanged in relatively mild pneumonia. This discrepancy suggests that there might be growing overdiagnosis of relatively mild pneumonia with increased chest CT utilization. The population-level mortality rate of pneumonia exhibited mild gradual decrease between 2009 and 2018. There might be multiple contributors of this phenomenon, including improved vaccination, advancements in treatment, and improved accessibility to healthcare system. It remains unknown whether increased utilization of chest CT was a contributor to decreased mortality of pneumonia patients, and further studies might be warranted to answer this question. Several limitations of this study should be addressed. First, arbitrary definitions of study variables were inevitable for the analysis of insurance claim database. Second, clinical circumstances for chest CT acquisition, that is, whether the chest CT was obtained for diagnosis of pneumonia or other purposes, cannot be determined in insurance claim data. Third, influences of outbreaks of certain infectious diseases on the study remains unknown. And finally, it is uncertain whether the result of this study observed in Korean older adults can be generalizable to other populations. In conclusion, there was a growing tendency of chest CT acquisition in older adult patients with pneumonia between 2009 and 2018. regardless of severity of pneumonia. During the period, incidence rate of pneumonia increased, mainly in pneumonia with chest CT acquisition. Further investigations are warranted to confirm the influence of growing utilization of chest CT on mortality risk and overdiagnosis in patients with pneumonia. Thank you for listening.